What I'm going to talk about is in the general theme of healthcare innovation from the perspective of a large payer who's actively involved in participating in the transformation of healthcare and hopefully catalyzing some of the innovation that's going on and being an innovator itself. We also have Aetna has been fairly active in acquisitions, so oftentimes it may also represent an exit path for some of the exciting new companies that are being formed. So I want to tell you about the kinds of things that we're seeing, the kinds of things that we're thinking about, where the innovation is happening, what we think some of the hot areas are, and then the role that we're playing in innovation. A couple things to set the stage. That we're at as you all know, and as Zaveen said, we're at an inflection point in history with healthcare, and there have been a couple of those over the last century. You know, the change in healthcare that came along with following the Flexner Report in 1929, the creation of the Blues, the formation of Medicare and Medicaid, the creation of the HMO industry. All of these have been important inflection points, and I think we're at another one right now for a variety of reasons. Healthcare is fundamentally going to change for the 21st century, and there are a couple of drivers for that. One of them is obviously the access and affordability gap and the growth in healthcare costs, which is no longer sustainable by cost shifting to commercial payers from what Medicare and Medicaid don't cover for the cost of care. Another one is the growing disease burden with a growing aging population with the result of unhealthy behaviors, excess growth in obesity, rise in diabetes, and an aging population. Another is the provider cultural change that's occurred, that now the majority of physicians are in employed relationships, and that number is increasing all the time. Physicians are interested now increasingly in lifestyle as opposed to, say, 50 years ago. There's a consumer cultural change. We were talking a little bit earlier about a fascinating video that I saw the other day where there was a 2-year-old playing with an iPad and had unable to walk, unable to talk, but had complete facility at swiping the pages across and pressing on and expanding the pages and pinching and expanding those. And then when Dad put a magazine in front of the little toddler, was trying to swipe the pages of the magazine and press on the page to expand it and pinch and so forth. And then finally started looking at her finger like there was something wrong with her finger. And the caption there was to a 2-year-old, an iPad, a magazine is just a broken iPad. So there's an enormous cultural change underway in the way that we interact with both technology and society. Technical innovations that are enabling things like social networking and the advent of mobile and use of game mechanics, for example, in the way that we think about and interact with society. An employer demands for value. Now, this is a world that we live in a lot as a large payer. We're seeing a shift with employers starting to ask for more and more value from the services that are provided from the supply side of healthcare, which is the provider or side of the equation, for lower cost, greater value, greater evidence of value that's being produced, and starting to demand things like value-based networks. And of course, the tipping function in all of this has been healthcare reform. So when you ask the question about why this isn't managed care in the 90s that we're in again, it's because in the 90s, Medicare was not part of the equation. It was all, the innovation was done on the commercial side, but now CMS is involved with both Medicare and Medicaid, and for most hospitals, Medicare reimbursement is about 55% of their entire revenues. And then finally, there's a global change in healthcare underway as well, that if we think it's bad in the United States with the rising cost of healthcare, it's worse in most other countries around the world. Just take a look at countries like India and China that are looking at healthcare growth rates of upwards of 20% annually, with the creation of the largest middle class on the face of the earth in China, and the growing demand for Western-style medicine, the increasing problems that countries around the world are having with obesity, and smoking, for example. So their interest in healthcare and getting under controls is even more acute in many cases than the U.S. So all of these things, there's a confluence of these kinds of forces coming together, and that's why this isn't managed care in the 90s, and that's why healthcare needs to fundamentally change. And when there's change, there's opportunity. And that opportunity is coming in the form of innovation. Innovation that addresses these kinds of issues, and innovation that takes advantage of the healthcare legislation that in the Reform Act. So I'm going to talk a little bit about some of the themes of where that innovation is occurring and some of the things that we're looking at and have been looking at, the rabbit holes that we tend to poke into. We've probably looked at more than 400 companies over the last 2 years for a whole variety of reasons. We're actively forming companies ourselves. So we'll go through some of the areas that have been on the horizon for us and what we're seeing around. Well, the first is under the theme of value-based care. And there are a number of different ways that this is being experienced. There is pay-for-performance, which I think has been going on for the last couple of years on the commercial side and now increasingly with CMS in the form of, let's say, gain share arrangements for a particular population where savings occur from a prior year's budget. Additional payments for achieving certain quality metrics. And then the converse of that is penalties for not achieving certain things or not paying for certain never events or readmissions. There's patient-centered medical homes, or PCMHs, and I think if any of you doesn't know what a patient-centered medical home, it's a way that a medical group or a physician practice can take accountability and responsibility for a pan or a population holistically across the continuum of care, where he's reimbursed based on the value that's delivered in terms of total cost, quality, and satisfaction. So it's a way that an individual physician or practice becomes accountable. And the kinds of skills that they need to deploy to manage that has a lot to do with care management, care coordination, not just episodes of care. Accountable care organizations, I think everybody knows what ACOs are. Big phenomenon, I'll talk more about that. Bundled payments, there are a number of bundled payment demonstration projects going on now with CMS, and people are actively trying to figure out what kinds of bundles make sense. Is it specific procedural bundles? Is it disease condition bundles? Are there certain episodes? What are the bundles that make sense? How do you actually track, monitor those? And how do you get reimbursed for those kinds of things? A lot of activity there, and there's a lack of capability within the providers to be able to manage those bundles. And then value-based networks. So if you have, we're seeing a lot of employers that are asking for the new networks to be value-based networks. So rather than a narrow network, and a narrow network being just an assembled network of providers that might be low cost, high efficiency, value network would be one there where there are ACOs and patient-centered medical homes, so that you get the triple aim. In addition to the low cost of care, you get high quality of care and high satisfaction with that. And within each of these areas, there are enabling capabilities that are being created and companies being formed to address those. Another area is health system redesign that's going on. So health system redesign, I'm thinking about physician realignment. So physicians going into employed relationships. Physicians going into new structures like the redux of the FICORs and Med Partners. Physicians creating urgent care networks, for example. Healthcare extenders and allied health professionals forming new approaches, retail clinics, and the like. Clinical integration, so health systems integrating with home health care agencies or creating their own home health care agencies, employing physicians, and building out structures that allow them to provide a more coordinated and integrated product, regardless of whether they're ACOs or not. Care management, hotbed of activity. So a lot of physician groups now that want to become patient-centered medical homes, or they want to participate in an ACO, don't have the capabilities to do care management, which is something that typically payers do. A hospital's approach to care management is generally utilization management, and managing a stay and obtaining pre-certification or authorization for the visit. It's not involved in managing the patient's transition between different settings of care and managing the patient between visits. And this is an investment that providers have to make in order to do that. Transitions in care is another one that's important now. So CMS is going to be penalizing healthcare systems for readmissions in the first 30 days that are otherwise avoidable, penalizing them in a variety of different ways. So now the healthcare system has to invest in the ability to manage that transition and make sure that the congestive heart failure patient or the ischemic heart disease patient or COPD patient, when they get home, they actually follow the program. They fill their medications, they take their medications, they eat right, they get all the follow-up visits they need, because if they don't, they're going to bounce back. So now the health system has to invest in those capabilities to do that, or employ a third-party company that can do that. And there are companies sprouting up all over to do just this. Telemedicine, another area. It's been around for a long time, but now it has the opportunity to be a lower-cost alternative to traditional care. And if you're an ACO and you're at risk, that you need to have lower-cost solutions to take care of patients. Alternate sites, I mentioned the use of allied practitioners working at the top of their license, and then fundamentally addressing the cost structure of their healthcare system. So these are hot areas that we care about and we focus a lot on. There's another topic of payer-provider convergence. So with accountability and risk shifting to providers, they start looking a lot like payers. And they don't have the capabilities that payers have to do the kinds of things that payers do. Things like understanding and managing risk, having a actuarial perspective on the data that might be available in their health system to understand how much the care is going to cost going forward, to analyze and understand their population that they serve, to identify who the 5% are that are going to drive 40% of the costs next year, and to be able to target and drill down on those people, to be able to engage with the broker and employer community so that they can actually distribute their product directly to employers or to the exchanges, to be able to organize a network of providers, monitor that network and its performance, and to be able to serve members, process claims, et cetera. These are all capabilities that providers don't have, but they need to have those if they're going to assume risk in many cases and actually take a product directly to the marketplace. So you're starting to see payers and providers converging in one way or another, either a payer buying a provider organization, and we've seen some of that. We have a number of payers. United has purchased a number of provider organizations. WellPoint has purchased CareMore, and Humana has purchased Concentra. And so there are a number of examples where payers are purchasing providers, and then there are other examples where providers are launching their own health plans and creating products that they can take directly to employers and to the exchanges. Population health IT is another hot area that there's a lot going on and a lot needs to go on. So when we think about population health IT, there are a number of different components of that. One of them is aggregating data that's available now. We have, thanks to the Stimulus Act and the legislation recently that has enabled stimulated the adoption of electronic healthcare records. Now we're starting to see a sea of clinical data that we've never seen before. So being able to access and aggregate that data is important. Being able to marry that with claims data and provide an integrated longitudinal view of a population and a patient is something that's new to the industry. A lot of invention is going on to access, integrate, and normalize that data. There's an analytics layer then that says, all right, what are the inferences that can be made on that data, both in terms of the cost, the quality, but also the system performance that's out there. So there are a number of companies that are sprouting up to address just those things. And payers have an enormous amount of capability in that area, but is traditionally claims-based in their ability to do those analytics. And so payers are reinventing or say, inventing the processes that are needed to actually integrate now clinical data into that and perform a view across that data. Care alerts, so another part of the population health management IT formula after data access, data analysis, and inferences is to understand the actions that need to be taken. So you identify the 5% of people that are going to drive the costs. Now you need to turn that into action. That means that somebody needs to be notified that Mrs. Jones needs to be put on a hypoglycemic agent, or that somebody's off their medications, hasn't refilled, or they're trending in the wrong direction. So these alerts need to go to the providers, they need to go to patients, et cetera. So actions need to be taken. Then care needs to be coordinated, so that means there needs to be a platform for collaboration, for messaging and communications, managing the workflow of care across the continuum. And then finally, there needs to be some means to engage patients in all of this, a patient engagement capability. So all of this is part of population health. Involves a personal health care record, and then finally, administrative services. So there's a lot of activity going in the population health arena. Another area that we're seeing is an increased focus on wellness. Now, it used to be that employers and plan sponsors were primarily focused on disease management, care management activities. And so there was a birth of a number of industries related to that. So you saw Healthways and a variety of companies that did disease management, case management, care management. There's an increasing focus now on wellness for a variety of reasons. One is to try and prevent the kinds of things that will eventually add to high costs down the road, but just as an employee retention and a competitive asset that employers have so they can attract and retain talent. So things like health and wellness, fitness, diet, smoking cessation programs, et cetera, that are important to address things like obesity and pre-diabetic patients. These are coupled with a high deductible health plan that provides incentives for healthy behaviors. And so what we're seeing is now models that look to achieve this with high efficiency, high levels of engagement at relatively low cost, using things like social, mobile, and game mechanics to achieve this. So you see companies like Red Brick and Cafe Well Talk and others that are trying to experiment now with these new means of doing it. Increasingly in the RFPs that we're seeing coming through the door with our active health unit, we're seeing a lot of this actually in the RFP. Tell me what you're doing with health and wellness. What are the programs and services? What kinds of engagement rates do you get? And these are expected to be at a relatively low cost. Consumer engagement now is not only required as a part of Meaningful Use 2 for the adoption of electronic healthcare records, it's now expected increasingly by patients. Individuals and consumers are experiencing industries in completely different ways. They have OpenTable at their .com at their fingertips. They have the ability to do banking transactions on a mobile device. They expect no less with the healthcare industry. They're increasingly empowered by transparent information. So they're expecting information transparency. They want to have access to their personal healthcare records. I have relatives and family members who now will pick their physician based on whether or not the physician allows them to see their medical record and will do email with them. That's something that never occurred before. I live in San Francisco, and it's common in the Bay Area now that's an expectation that patients have. There's a concept of social caregiving. So social caregiving, we've got Facebook that allows people to collaborate around anything from having fun to work to with LinkedIn, et cetera. Why can't people collaborate on the health care of somebody that they know and love? So if you have a loved one, for example, that has needs, why don't the children get together and collaborate around that through social tools and email and messaging and so forth? So social caregiving, you see companies like Patients Like Me and others that bring communities together that do more than just education, that allow people to share experiences. Crowdsourcing, another one. I don't know if any of you have heard ePatient Dave speak. ePatient Dave he's a gentleman that had cancer and was given a grave prognosis. And his doctors, who were high-quality physicians, had no treatment for him. So he went on the internet and went to places like Patients Like Me and chats and so forth, and he found that around the world, people with the same conditions with him were in all kinds of experimental treatments, and some were showing really good results. And he found the trials that were actually producing those results, brought those trials to his physicians. The physicians read about those trials and found out that they were producing good results, got him enrolled in those trials, and he was cured of his cancer. And so he's gone on the speaking tour, talked about the power of crowdsourcing that now is moving faster than the traditional medical community can keep up with. The concept of mobile health, I'm going to talk more about that in a minute. The use of game mechanics. So, for example, I don't know if anybody here has a teenage son who plays World of Warcraft or Halo or something like that. But what is it about that compels those kids to do it over and over and over again? There's some kind of neural or behavioral feedback loop that gives them a self-reinforcing drive to do this. Can we bake those into certain healthcare tools and activities and services so health and wellness activities are self-reinforcing? So you're seeing a lot of that kind of invention going on. And then in telemedicine. So it's a little bit of a flyby of what some of the hot areas are and some of the change where innovation is occurring. Now I want to shift a little bit to, so why does that matter to us? Why does it matter to a large payer? It matters for a number of reasons. There's a fundamental transformation underway in healthcare. The legacy business models of the insurance industry over the last 20 years see this, or should see this, as an opportunity to change and adapt. So the traditional model where value is created by driving discounts to traditional care and then serving up those discounts is in the long term not a sustainable model. If a health plan is successful in forcing the lowest possible discount, they'll drive out every last nickel of profit from the provider, and the provider won't have the ability to invest in the care management they need to manage the population. There has to be a different model, and that model has to be a collaborative one between payers and providers where we're creating value together and bringing that value to employers. So it's an opportunity to reinvent the legacy model. So we care about that, and we want to be part of that transformation. Another reason that we should care is that profits are being increasingly regulated. A lot more regulation now on insurance products. It's going to be specified in the exchanges. The medical loss ratio limit is regulated. You can no longer exclude people that have prior conditions. There are a number of regulated components to the insurance product now that weren't there before. Employers are looking for greater value. I've heard one of the large airplane manufacturers in a presentation that I heard about a year ago to providers was describing the future that they were going to have to get used to. And the fact that for every airplane they manufactured, the first 35 million or so of it was to cover their retiree benefit, healthcare benefit. And the planes that are manufactured in Brazil and China don't have that burden. And so that's what they're competing against. And so they have to actually go back to the provider community and say, help us out with this. Let's work together to get those costs down. So employers are looking for increasing value, and the payers can no longer cost shift that onto the commercial population. I mentioned that providers are taking on more risk. They're starting to look like payers. That means that payers have new competitors in the marketplace. So we need to figure out, are we part of that movement, or are we in opposition to that movement? The exchanges and high deductible health plans are putting consumers in the driver's seat in a decision-making role, where previously the payer's relationship was primarily with the employer, and the member was a component of that. But now, with the financial responsibility shifting to the consumer, consumers going to the exchanges and making their own independent decisions on the insurance products that they select. The payers need to start thinking about members as consumers, and they need to start forming enduring relationships with individuals. And that's a shift in the thinking. They need to start being more retail-oriented and thinking about consumers. So the healthcare landscape is being reinvented for the 21st century, and with that comes opportunity for payers, opportunities to reinvent their business models to create new value and make investments and bets in the future. So there's a lot of innovation in the United States that's been fueled by private investment from the venture community, from private equity. And it's been a very powerful force for a variety of industries. And there's some natural advantages that venture investing has. It compared, say, to what's delivered by large companies. And the models are nimble and efficient. They are unburdened by significant operating mechanisms and bureaucracy. Decision making is oftentimes very streamlined in these organizations. They have access to entrepreneurial talent that has a different risk acceptance profile. And the equity incentive structures can be powerful motivators. These are something that generally large strategic organizations lack, but it's characteristic of venture. I would say that venture has some challenges, though, in healthcare that may not exist in other industries. One is that healthcare is a very highly regulated industry, so the degrees of freedom that you have are sometimes more constricted, and it takes a long time to get things done in healthcare because of that regulation. And you have very conservative buyers with very long sales cycles. So you have to be in it for a long time to produce results. A lot of the value that needs to be created depends on interaction with the healthcare system, doing transactions and having access to data, and the legacy systems are locked up tight and hard to crack into. And it's hard to get the attention of a 900-pound gorilla and I won't name names here, but you know what some of those are, where you're too small to matter. And it's not worth the time and the cost to do that investment. And an interface to a typical system that might take a week or 2 weeks and $15,000 with a large health plan can take a year and $2 million. Because of these massive systems that have so much functionality that even a small little change has ripple effects across all of their lines of business. So they have to be very careful and methodical about how they do that. The other challenge that startups have in the venture world in healthcare is access to distribution and scale. So you have a lot of innovative startups, so how do they break out above the noise and actually get large-scale access, distribution? Because that distribution oftentimes is controlled by payers and is controlled by large health systems and others. So how, as a small company, do you break into that and you get that kind of distribution? Capital availability. There is, over the last several years, a lot of the traditional venture has shifted a bit from, say, early stage companies and seed round funding to later stage and growth equity investing. So where do the early stage companies get the capital to do that? There's an opportunity that large strategics have to place those kinds of bets that may not be as readily available. And then the final thing is that venture oftentimes doesn't have the kind of access to synergies that can produce value in a variety of different ways, other than purely financial value. So let me flip it then, take the converse. That payers ought to be well positioned to be part of the formation and the innovation in healthcare for a variety of reasons. First of all, they've got some enormous assets that they own. They've invested in over decades. One of those is data, enormous amounts of data. The other is analytical power and analytical capabilities. So I think Aetna probably has one of the largest actuarial departments and teams in the United States, if not the world. And that's an enormous asset. And now with providers that need to, or companies that need to have those capabilities, where do they get those? Where do those legions of actuaries come from? So the analytics is another asset that they have. Care management resources. So we as a payer have thousands of people that do care management in call centers around the world, and those kinds of things are so the marginal cost of adding a care management capability on another a provider organization is small compared to trying to hire those people up in, say, areas of the U.S. where the talent doesn't exist. We have insurance licenses in most of the states, that take time to get and oftentimes are difficult to get. Payers have an enormous distribution channel in both their ability to aggregate members and consumers with their employer relationships and relationships with brokers and agents and benefits consultants. They have vast provider networks. We have upwards of 6,000 hospitals and 800,000 physicians in the networks. And they have an infrastructure for engaging and managing members in those relationships. Payers have access to capital. They have access to a variety of types of capital. One is risk-based capital. So if a provider organization wants to create a product in their marketplace, they have to set aside statutory capital as reserves against the risk that they're taking. Payers have that available. And so we have the insurance license and the risk-based capital available. They have balance sheet capital, and they have enormous, in many cases, free cash flow that can be used for investment purposes. And then the final thing is that they have potential synergies. So when we do an IT deal, for example, we create value in a variety, back to the core, in a variety of different ways. The value in terms of the premium revenues that we get from the relationship that gets formed and the new members that get attracted, the impact on medical loss ratio and cost of care that is improved, the discount positions that we can renegotiate as a result of that, and all types of value that can be derived as a result of that IT, so that the IT can be paid for in a whole variety of different ways. A startup company that just purely has IT as its only value proposition has to monetize that through technology fees. And so they could be at a competitive disadvantage as a result of that. So payers have all these theoretical capabilities. But for some reason or another, payers have not historically been the chief innovators in healthcare for a variety of reasons. In fact, very few big companies are innovators, very large companies. And point to one large company that has really been an innovator. There have been a couple, Apple, for example. But by and large, most large companies are incrementalists rather than innovators, and they more acquire than they do start up. And the acquisitions they do oftentimes are not successful because large organizations have a difficult time with startup and entrepreneurial organizations. The syndrome of mama bear rolling over on the cubs and killing them. There are a number of reasons for that. One is the operating model and the culture. Particularly with payer organizations that are highly regulated and public companies, and the operating models have to have layers of controls to manage the risk that they undertake, and that involves processes and a culture that is counter to risk-taking. It's not the fleet, the nimble, the flexible. It's not something that, that entrepreneurs enjoy working in. Talent, different type of DNA. Not people who are the Renaissance people that are comfortable with taking calculated risks. They're people that actually are more operators. People that work hard, they do their job, but it's a very different DNA profile. The legacy IT systems that payers typically have are very different than what the marketplace is asking now for things like mobile and social and game. These are systems that have grown out of decades of COBOL, for doing transaction processing and managing big data. The incentive structures are different. So there's a very big difference between stock options that are directly tied to the value that you as an entrepreneur create versus equity, for example, in the mothership that might move incrementally at a glacial pace compared to the value that you might create. Accounting treatment. So if a large company is investing in innovation, it invests that a lot of those investments come out of OpEx, and OpEx puts a drag on EPS. And for public companies that have to report quarterly, there's a trade-off with the R&D budget versus the ability to do the quarterly reporting to the numbers. And if there's an investment in a company that where you have to consolidate it, it really doesn't matter. And so the ability to, say, invest off the balance sheet or CapEx, might be a little bit limited as compared to, say, a fund that you could raise from limiteds, where you have the freedom to, invest out of that fund. That's a very different kind of approach and perspective that both large payers and public companies might have. So given all those constraints, I want to now focus a little bit about how we're addressing that, how we're attacking it, and how we're actually participating in innovation in the United States, both in the creation of new companies and also in acquisitions. So we have a different kind of a model. When we went into this about 2 years ago, we thought that we need to be part of this transformation. We have new CEO, Mark Bertolini, who's a visionary and a huge supporter of enabling the future in the 21st century. So the question for us is, how can we take the vast resources that we as Aetna have and not only participate in innovation in healthcare, but actually catalyze it and lead it? And we had to invent different operating models and different structures for that. And so we created a business formerly known as Emerging Businesses within Aetna, recently renamed Healthagen, with the name announcement that came at the HIMSS conference recently. And it has a number of factors that are different from the traditional approach, and I wanted to go through. First of all, it starts with a leadership vision and executive support at the very top, that this is going to be a different entity with different operating models, different culture, different approach to doing businesses than the core business. The operating model is designed to be lean, efficient, entrepreneurial in its design, with a minimum amount of bureaucracy and operating process overlay, and an enabling culture behind that. That the individuals that populate the company will be handpicked from venture and private equity and people that have actually done startups before and been part of that, of startup companies. So they understand and bring that DNA and culture with them. And then across the 35,000 people at Aetna, selected individuals that have that in their background or have that kind of mindset and way of thinking. We decided to approach this by a combination of both incubating startup companies and making strategic acquisitions at any stage in the business cycle. So both early stage investments and acquisitions, late stage buyout, and partnerships with other companies. So being flexible in the approach that we were taking. So there's not a number that of a size check that we were looking to write. It's more a capability that we had and a return on the investment in that capability at whatever the size that was. So very flexible and creative in the way that we would deploy capital to both incubate, start businesses, but also make investments. It was important that we would leverage the assets that we have so that we can take advantage of fixed cost investments that we've already made. That we would not just be a passive portfolio of companies, but that we would be an active manager of those companies so that we could actively drive the synergies that are created from the companies that we would either create or acquire. That we would take a long-term portfolio view on these and not just a quarter-to-quarter focus on financial results. And that we would create incentive structures for the people that worked in these that were aligned to the value that gets created, that would be competitive with, say, stock options or other types of vehicles or carried interests that might be in the marketplace. So these were design principles that we needed to put in place from the get-go. And we've been largely successful in doing that, and so we've created this business called Healthagen. And the goals were simple. Number one, it was all about innovation, transformation, and driving synergies back to the core, to core business. We have three main areas of focus. Success is all about focus. And those three areas are principally non-regulated, non-insurance businesses that have attractive financial profiles, but are in the path of inexorable social trends and market forces that address the transformation of healthcare and that drive synergies back to the core business. So three principal areas. One is provider enablement under the new reform era, consumer engagement, to be active and richly engaged and activated in their own care, and population health IT. These are three principal areas of focus. As I mentioned, the approach involves both acquiring growing companies and incubating startups, and I would say partnerships as well, where we might take an equity position in a company or not, and then that creates a portfolio. We have we eat what we kill, so that means that we have operating responsibility for these businesses and actively manage them to produce the synergies that get created. And the companies, they have some either strategic interrelationship with themselves or with the mothership, so that it's not, there's method to the madness. There's a purpose to what's created. So how do we go about creating? Let's talk a little bit about the startup process. How do we go about creating them? Well, first of all, we're constantly looking at the marketplace, tracking healthcare trends. We're constantly looking at companies that are out there, new companies and startups and investor activity, to see what the hot areas are, and is there a better mousetrap, or is there an opportunity to acquire a company and maybe another one and put them together and create new value. So we're constantly looking at what the market is doing. We're constantly looking at Aetna and the business needs that we have. unmet gaps, what we're hearing from our operating divisions about things that they need that are on the horizon. And we're constantly talking to our customers, employers and others, to figure out what do they want, what unmet needs are there, what pain points are there. And then we're distilling those down. We analyze those and we create short lists of where that we think that innovation needs to occur or there's opportunity. And then we look to see where there are synergies to be had with the core business. And then finally, is that an attractive business? Does it have an attractive financial profile, high margin, high growth, recurring revenues, et cetera? And then from that flows a formalized process for new business formation. It involves a concept development. It involves a business plan creation that we pressure test in the marketplace. It involves development of a prototype, a technical prototype for the product, piloting with our large distribution channel partners, employers, and others, and then eventually a commercial launch. So there's a structure to that process. We also have method to the madness to prioritize the kinds of things that we think are important based on the strategic fit to Aetna, the speed, effort, and cost to get these, and then the girth that gets created and the impact. Looking at things like the ability to close a gap or drive value back to the company. So in the early first 2 years of this, we either started or acquired about 10 companies. We do about a couple a year of either new businesses that we create or startups that we do. And our experience in the first couple of years was that the time to get to commercial was about 2 years with each of these businesses. So we asked ourselves, is there a way that we can actually accelerate that? And so we invented an acceleration process, and I'll mention that to you. It's I think there may be a number of you that work with various healthcare accelerators around the country, and there are a large number of those. This is the way that we approach it. And this was born out of experience that we had with our hackathons. We do these things called hackathons. That, in fact, I think Pete, the CEO of one of our companies, iTriage, is here, and I think your engineers were involved in one of this. And the challenge was, it takes us a year and $1 million to do to build something with the mothership IT just because of the complexities of those systems. And so we asked the question, if we got our smartest engineers together with some users, locked them in a room for a week, slipped pizza under the door and fed them Red Bull, and said, you can't come out until you have working software. Could they do that? And so some Pete's engineers and some of Medici's engineers went into a room, and a week later, sure enough, they came out and they had working software that fixed the problem, short-circuited that entire thing by about a year. And so then we said, well, if we can do this for software, can we do it for a business problem? Can we actually take our smart consultants and can we mix these in with our buyers on the employer side and users, like members or people that we just get off of Craigslist that might have that problem, with our software engineers and designers, and lock them in the room and say, you can't come out until you have a problem solved, you've got a business plan, you've got a wireframe demo that you've built, and you've got a financial pro forma put together. In other words, a very, very focused, concentrated business planning exercise. And so we did that. We put that process together. We call it Slingshot. And it's been very, very successful in defining some new businesses for us. And it has the added benefit of you've got some large employers who've already raised their hand and say, I want to pilot that because I was part of the creation of that idea. And it cuts the time in about half. Overall. So that's the Slingshot process. We use that as part of our new business ideation and creation. We created a structure that has some shared services across, like IT, marketing, and consulting and business development that are not Aetna. We take from Aetna only the business processes that are of value to Aetna, and we're free to buy outside, in the outside market for businesses if we can find something at a lower cost that better fits our needs. That's a very different model from other large companies that enforce that inside. So these are some of the businesses that we've created. I'm naming only the ones that have been publicly announced. There are a number in here that are in pilot that I won't name. So in provider enablement, we created Accountable Care Solutions 2 years ago. We created one called Practice IQ, which enables patient-centered medical homes for physician groups. In the population health IT, we have iTriage, a company that we acquired, early stage company we acquired about a year and a half ago. Medisti, the largest health information exchange in the country. Active Health, which was acquired in 2005, one of the largest clinical analytics and care management companies. Created a company called WellMatch, which uses price transparency to enable people to more rationally select providers and care. And I'll say a comment about each of these. So Accountable Care Solutions was started 2 years ago, and it's probably one of the largest now in the nation in ACO enablement. The approach that we took was a completely payer-agnostic approach because we felt that providers don't want to do one thing for Aetna patients different from somebody else's patients, et cetera. They needed to have an infrastructure solution. So we brought all of our assets to bear, our health IT assets, care management assets, and health plan, intellectual property and capabilities in a model that enables them to broadly engage in accountable care across all payer populations. Medicare, Medicaid, their own commercial lives, their own employees, et cetera, and to create their own white label products that they can go directly to the marketplace with, so employers and exchanges, et cetera. And to date, we've done about 20 ACOs that we've announced, and we've got a very large pipeline of some 200 plus systems. We've done 3 statewide ACOs, a very large number of Medicare Advantage plans and PCMHs and others. So it's been very successful. Medisti, largest health information exchange in the United States, more than 800 hospitals and 200,000 physicians connected. Active Health, serving more than 20 million lives in one form or another, not only Aetna, but large employers and other payers for clinical analytics and care management. Practice IQ, as I mentioned, for physician practice and IPAs that want to bear accountability and risk. iTriage, a company that we acquired, as I mentioned, about 1.5 years ago, which at the time was a very early stage company that had this brilliant idea started by a couple of ER docs to drive people from symptom to provider. So most technologies that were out there were addressing engaging people in a different way, where somebody already knew they had an ACL tear and they just needed to find the sports medicine physician that can that can get them an MRI. That's not the way that people interact with the healthcare system. They have a vague notion of what they need, and they may not actually know what it is or what type of resources is most appropriate. So iTriage helps them, goes way upstream and helps them solve for that symptom question, and then use the location awareness features of the mobile device to then serve up providers who are most appropriate to that circumstance, and then allows them in many cases to see the waiting times to be seen, to actually pre-register or book an appointment directly. And so guidance, transparency, action, all in one mobile device. We broadened that because of success. They had about a little bit more than 2 million downloads when we first met them. They have now, I think, more than 9 million downloads, one of the top 10 consumer apps in the world, mobile apps in the world. And we have broadened that now to include health plan functionality, so that if they declare who their network, who their payer is, then the choices that come up are informed by who's in network, what's covered by their benefits, what their deductible status is. They have an insurance card that they can present and show. They have access to their claim history, personal health care record, et cetera. When they book an appointment, the visit is concluded, they have a clinical inbox where results can flow into. So a comprehensive walk from symptom to conclusion of the event. And we do track, by the way, results. So there are some 45,000 reviews that are posted on the Apple iTunes store, and we track and read those. And this is one that we pulled out, and I don't know if you can read that. It says, I was not feeling well, then I got jaw pain. I looked at the symptom up on iTriage and saw myocardial infarction. I looked at the other symptoms and called 911. Sure enough, I had a heart attack. iTriage saved my heart and my life. We've got numerous episodes. We had one person that actually called his health plan. It wasn't Aetna. The advice line, and they said to see his doctor in the morning. He went to iTriage and thought that it might be a heart attack, went to the ER, and then had a cardiac arrest in the ER. Was successfully resuscitated, successfully discharged, wrote a review like that. Where else have you ever seen software that has saved somebody's life? This is a disruptive game changer. And so we love this company. And then finally, I'm going to mention WellMatch, and then we'll open it up for questions. So WellMatch is a company that is another disruptive company that we've just created, and it's going into pilots right now. And that involves combining price transparency. So if you do know you have to have a procedure, that there's a wide range and variation in price. And we know, if you're an Aetna member, exactly what that price is, because we can adjudicate that claim in real time and show you not only what it is, but what your out-of-pocket, the deductible, and everything is going to be. So we have a member payment estimator that is highly, highly sophisticated. So let's make that capability available to you in a mobile device for employees, and then go one step further. Allow them to, say, using the power of iTriage, to search for and find the right provider, take action and book an appointment with that individual. And then you go one step further even, and that is to, say, combine that with a discounts, a Groupon-like model where providers who have excess capacity can actually make that available at a discount, and then you can include that in the formula. So we can actually leverage the power of available capacity to drive further discounts on top of the already discounted rates. So a very comprehensive and sophisticated way to use transparency to empower individuals to make smart choices. So that's just an example of one. So I've taken a couple as case examples, but just to illustrate how the areas that we're interested in, how we think about innovation, both in terms of startups and in acquisitions, and then some examples of some things that we've done. So with that, I'm going to pause and just ask if there are any questions or comments or anything that you'd like to talk about.
Okay. Clearly, one of the major thrusts of the change in healthcare that you were talking about and everybody's talking about right now, to me, pertains to the alignment of the responsibilities of payers with the responsibilities of providers. And it looks to me a lot like 10 to 15 years ago, per member per month payments to physician groups, Aetna, Humana, others trying to institute therapeutic protocols, care pathways, so on and so forth. And in that period, it resulted in big bankruptcies of physician groups and some hospital systems, major lawsuits, if I recall correctly, against the Aetnas and Humanas and such for getting involved in these sort of provider decisions. How can we make it different this time around?
That's a good question. So one thing it did do was to blunt trend. So the healthcare growth trend was actually flattened during that period of time. So the principles are effective. And the challenges or the problems that we had in those days is, number one, you didn't have the data that you needed to make informed decisions. So providers signed up for risks that they didn't know what it was really going to cost them. And they did it generally for competitive reasons and out of fear, et cetera. So didn't have the tools and infrastructure to actually manage care. And then most importantly, CMS and Medicare were not in it with incentives, because there's so much savings to be had in a high-cost Medicare population that the savings from that can actually drive a lot of investment. So none of that was available. I think now we've got far more mature technology that's hardened and it works and it's real. We've learned a lot of care management lessons. The approach that's being taken from a finance is not just turn over global cap reimbursement mechanisms. It's actually allowing systems to incrementally build based on a fee-for-service mechanism if they want to, where they use gain shares from the savings, and also giving patients choice. In those days, it was a gatekeeper model, and patients saw this as rationalization of choice. And nowadays, choice is retained, and we're giving them transparent information, armed with financial incentives to make a choice that's aligned with the interests of everybody in the healthcare system. So, I think the expectations are one that we've learned from 20 years ago, that it's a new day in terms of the capabilities, and that we don't have a choice as a country in terms of just the cost of care. So, we're working with. The other thing, I think that the payers and providers were still on opposite sides of the table, negotiating a cap rate. We're on the same side of the table now with providers. We're in this with them. We want them to be successful, so we're opening up our armamentarium of capabilities and being very transparent about costs and working together to drive those costs down.
As you look out in the future, do you see less people getting their insurance from employers, and how is that going to affect your business, or do you think that's going to be a stable phenomenon? And how does any of this innovation affect the costs of Medicaid and people who are not employed or not educated?
Well, one of the things that I want to avoid doing is making any predictions about the future, for a variety of reasons, not the least of which we're in a quiet period. And partly because I just don't know the answer to that. I think that anybody can speculate on how many people are going to flock to exchanges and how many people employers will go to defined contribution rather than defined benefit, and how successful the exchanges will be. We are hoping to participate robustly in all of that, in whichever way the market turns, and I think that we have the capabilities to be successful in any outcome. So, but I can't predict for you how it's going to play out in those particular areas. Yeah.
Do you have any words of advice for those who may be introducing new technologies into the market, let's say on the device side, which is particularly relevant in my case, in terms of navigating the process, the traditional process after one goes through the Medicare process and the regional fiscal intermediaries, and then interacting with the payers on a regional and then on or state and then a national basis? It's been an adversarial relationship. It's been pretty much beaten down, no until there's proper evidence. Yet on the other hand, a lot of these represent significant disruptive technologies with great data, and often these solutions are ones that are extraordinarily cost effective. So given all these, the new ecosystem that's emerging, are there any angles of pursuit that you think would be unique and different than the traditional, do 10 clinical studies, spend 5 years negotiating, and eventually, get to a tipping point?
Well, I guess two things to say about that. It's that there does seem to be a trend in the U.S. to have a prove to me or show me mentality that this will actually reduce cost before we actually allow the investment and the payers start paying for it, and that CMS covers it. So that is a trend. To the extent that even words like comparative effectiveness now are part of our vernacular. On the other hand, I know that we as Aetna do a lot of pilots with our membership, with medical devices and programs, et cetera, if they have face value validity that they ought to work. So we do a lot of that kind of partnering with entities to determine whether they are effective. So I mean, I would just say that if there is a product that has that kind of promise, you've got to go down both paths. Convince and show people that it might work, and there will be both health systems and payers that are interested in experimenting with it, potentially if the value looks like it's potentially real. But I won't kid anybody that it seems like that there is a trend towards a higher bar of proof before that it gets broadly reimbursed. Yes.
You talk about a company like iTriage and how technology helps access consumer data to help create value. How do you guys interact with providers and healthcare IT companies that they use, the Cerners and the Epics of the world?
For getting data out of provider systems, that our core asset for doing that is Medicity. That's the business that Medicity is in. They, as I mentioned, hundreds of thousands of physicians and close to 1,000 hospitals. And every day they're interfacing with Cerner and with Centricity and with Epic and others to do exchange of clinical data. So they're the pros from Dover, on our team that do that. And they're not everywhere. We do have other ETL processes where we can actually directly interface and tap in. So we have them in Active Health, we have them in others, so that we can create those interfaces and bridges where we need to. That's going to be a fact of life for a long, long time, because data standardization is probably more of a concept than it is a reality, at least in the near term. The converse, by the way, is an interesting question, that how do we externalize data so that others can consume it? So we have an initiative at Aetna called CarePass, where we're actually making that information, member information and other types of information available to the marketplace through standard APIs, interfaces, toolkits, and SDKs, so that third-party companies can actually easily integrate that and bring value. And so we're unlocking the power of the data there so innovation can flourish, even if it's not Aetna innovation. And that's the CarePass initiative. It's headed by Martha Wofford, if you want to follow up on that. And I think they've got about 60 or 80 companies now that are connected and consuming that kind of data. Yes?
All the savings that we're talking about, the economic engine behind all of it, relies to a certain degree on changing here are consumers making better choice. So outside of the payer world, who do you see that does a good job engaging and influencing consumers at scale?
Yeah, so how do you change consumer behavior? I'll give you a couple of examples of where the paradigm is completely shifted. So when a payer engages a member for, let's say we identify who the high-risk individuals are, whether it's diabetes or what have you. That information is picked up by our care management team and the call centers, and then they start making phone calls, to try and get the individual. And let's say that they have a certain engagement rate. Now, payers, I won't say Aetna, but payers in general might have a 15 to 20 or 30% engagement rate, if they're persistent and follow through. What you're doing is you're asking an individual to return a phone call from their insurance company to tell them something that they need to do for their health care. And it's a long putt, to get that one done. And, but it is effective, and we do produce savings with that. We produce good savings on the commercial side and great savings on the Medicare side. There are more powerful ways to engage individuals in healthy behaviors. And they're, number one, financial incentives. So they have an HSA, they've got a high deductible plan, so now they're empowered. Give them information, transparent information, so they can actually make an informed choice. And so with our iTriage experience, if you serve up a variety of options, and they see an urgent care versus an ER, and all things being equal, they overwhelmingly pick the urgent care over the ER because it's, number one, more convenient, number two, less expensive. The third is to have that call come from their doctor. There are companies where that outbound contact or engagement actually comes from the physician, driven right out of the order set that the doc has in his EHR. So a diagnosis and a procedure code come up like this, follow-up visit, it's call this company, the company does the outreach on behalf of Dr. So-and-so, and their engagement rates are sensationally higher, or can be, compared to what a traditional payer would do, and they're more real time, and they're more in the context of a particular visit. I think you're going to see more and more of that as risk starts shifting to providers, rich tools for patient engagement, transparency, financial incentives, and providers actually getting in the game and participating in that engagement formula.